Hello, my name is Corey Trammell, and I'm a student at LSU MSW program. And today, for a group project, I'm going to be interviewing my mother, Miss Darlene Williams, on the subject matter of PTSD, post-traumatic stress disorder. Hello.
Hi.
Can you tell us a little bit about yourself, like your position at the VA and your position within the military?
Sure. I am a psychiatric nurse practitioner in the mental health clinic within our outpatient-based clinic. It's a CBOC, and I've been there for, I don't know, I guess about 5 years now. I've been in the clinic, the mental health clinic, the official mental health clinic, for 3 years, and then 2 years before that, I was in the primary care mental health integrated clinic. And then before that, I was at the VA in Biloxi, Mississippi, where I was for 2 years. Within the Army, I am a psychiatric nurse practitioner, or 66 Romeo, and I belong to a combat stress unit. That's a medical detachment within the Army. So we are a group of specialty providers. The mission of combat stress is prevention, but we also do treatment.
Okay.
Yeah, for about 9 years now.
So 9 years. And when did you join the military?
Oh, I joined in 2011.
Wow.
I was a very late bloomer. I joined when I was 46 years old.
Okay. Is there any particular reason why you joined the military and why you got into working at the VA?
Well, I joined the military somewhat on a whim. I joined because I was so very proud of you and what you were doing, and just really impressed and excited by it. I have your 2 uncles that have been in the Army, and Robert had been deployed. I want to say by that time he had already been deployed about 5 times and was getting ready to face another deployment. And Kevin was getting ready to face a deployment. And
I was deploying. We were all deployed at the same time.
Yes. And I can't say that it was well thought out. However, I have to say that it has been absolutely rewarding, completely rewarding.
Okay. All right. Some things about, your work at the VA. What we're talking about here today mainly is, PTSD with vets and members within the military. Can you give me some differences of how you treat veterans and those within the Army?
Yeah, so the mission in the Army is like I said, it's prevention. So we, as a combat stress unit, we are frequently, we're broken down into smaller based teams and attached to work with different commands. So, for example, we might be broken up into a small 3-man team, and our team might consist of somebody like myself, a psychiatric nurse practitioner. It might be a social worker. It might be a psychologist or psychiatrist. And then there's usually 2 psychiatric technicians that are part of the team, and they will send us forward to
Forwarding operating base.
Yeah, wherever the need is, usually it's going to be closer to the front lines. But the mission is to support those units that we've been assigned to work with. So it could be any kind of unit within the military. It could be an infantry unit. It could be a military police unit. It could be a medical unit, engineers, communications. It could be anything. But we try to integrate within that unit and get to know the unit members. And the more we can get to know them individually, the better positioned we are in order to do the prevention. So we try to reach out. We do what we call walkabouts, and just let people know, that we're there. That we have a presence there, that we have services available should they need. And it can be, we call them combat operational responses. So it could be like, I'm having problems getting along with my roommate, and come talk to us, and let's see if we can do some problem solving and some things that we can help them work out between themselves. Or it could be, I'm having problems with my command. I think my leadership is not doing right by me, or my immediate supervisor is not understanding me, whatever it is. So we try to help them work out the immediate types of problems. And then, of course, with the up tempo, we try to help provide services to keep, to manage stress. So we do stress management classes. We'll do sleep hygiene classes. We'll do exercise and nutrition. So if there's other military members that need mental health services, we can provide their services.
So what happens when you come across somebody who has PTSD but they still need to go and continue their job?
Well, we do our best to support them in completing their mission.
So what kind of treatment does that mean for them?
Well, it kind of depends on who they are as an individual, and where they are within their illness. So if I've treated soldiers that have had PTSD from 2 or 3 deployments that they've had now while having PTSD. And so they may come to me and say, okay, well, I just need a refill on my medication. They are supposed to be stabilized on a medication before they come into a combat theater. So I might just provide them medication. I might provide them with some supportive counseling and therapy. If it looks like, specific symptoms are getting worse, then we might do a little bit more intensive treatment to kind of get things stabilized. So whatever it is that that soldier needs as an individual to help them. If it looks like that they may be decompensating and really can't safely stay in that situation, then we have to medevac them out of theater. Another thing that we do as a combat stress unit, we provide what's called traumatic event management. So we're usually work pretty closely with the medical units, and so it's frequently a medical unit that will send us referrals for traumatic event management. So for example, we had a unit, it was a medical unit that had ended up treating several local children, and because healthcare, this was in Afghanistan, so healthcare was poor, and they lost several children. So we went up, and they had just recently lost a child. We try to get there within 24 to 32 hours. So we went up and we did it's called a traumatic event management, and that's not what we used to think of as an intervention, because an intervention, you're doing a lot of processing of mood and symptoms. So really what we're doing is support and guidance to leadership in those cases. So, for example, we had a combat arms unit that had lost several soldiers. And so we went in and we just kind of introduced ourselves. We allowed the soldiers to have a kind of a round robin where they introduced themselves, and they gave us just kind of a brief explanation of what the traumatic event was. And then but we don't want them to get into detail because, you know, that's, of course, we found out now that that can end up re-traumatizing people by making them do that.
Right.
But then we try to pull back and we let them know that we'll be around. We usually try to stay around for about 2 to 3 days after that. And we make sure that they have our contact information. We will try to get some feedback from them about what do they think is, you know, working for them, what is not working. We try to work with the leaders to provide supportive services. So it's really important that they have time to decompress, but we don't really want them to isolate too much. So we want to kind of keep them together as a group, but make sure that they're getting adequate rest, adequate nutrition, and time to do.
Maslow's hierarchy of needs, right?
Right. We kind of focus on that, and that's kind of the way when you're, you know, you're working with non-mental health or non-medical type of people. That's one of the ways that you might talk to them, is by explaining to them about Maslow's hierarchy of need. But one of the things that we do know is that it's extremely important for them to get back to work very quickly, because that sense of belonging and importance really is a major factor in decreasing the potential development of PTSD. So that's kind of another big thing that we do. And then we make sure that they have contact information for us. So if it's been a few days later and they start having some problems with sleeping or becoming anxious, or different mood symptoms, they can reach out to us and we can start doing whatever kind of treatments need to be taken care of. If it's just one-on-one counseling, or again, talking about some sleep hygiene, or do we need medication, or what, it depends on what their needs are.
Okay. All right. Well, now let's just switch over to the VA side. How, you know, how does it differ? What is assessment like in that scene, in the outpatient?
Well, we get vets coming in at all stages. So of course, you know, within the last few years, we've had a huge influx of the OEF, OIF vets. So a lot of very young soldiers coming in.
Can you explain to people what OEF and OIF are?
Yeah, OEF is Operation Enduring Freedom, which is Afghanistan, and then Operation Iraqi Freedom,
Okay.
which was in Iraq. So soldiers that had been deployed to those countries.
Right.
So if they're a combat vet and you were honorably discharged, then you have access to VA services. And so they can come to us through any number of ways. We have specifically a social worker who is assigned to that's her responsibility, is to work with OEF, OIF soldiers, help them, bring them into the VA system, orient them to the VA, and make sure that they get access or know how to access mental health services should they need mental health services.
Okay. So social workers actually refer to you?
Yes.
Okay.
Yeah. At the JAC, which is Joint Ambulatory Care Clinic, yeah, we have a social worker, and that's her primary position, is to work with the new OEF, OIF soldiers. So of course, you know, we have the first Gulf War and several other conflicts that people just don't think about, but then all going back to the Vietnam War, and we still occasionally have a World War II vet every now and then, which it's kind of cool to talk to them. They're actually really inspiring people. So they come in. One of the ways that they come into is into what's called the primary care mental health clinic. So if they come in and they're starting services and they go for their initial physical exam with their primary care provider, and part of a standard physical exam now is that they get a depression screener and a PTSD screener.
So these are some assessment tools that y'all use for this.
Yes,
Okay.
these are standard assessment tools, and they're done at the initial physical, they call it, oh gosh, I can't remember what they call it. Their vesting exam is what they call it.
Your vesting exam.
Yeah.
Okay.
So if those come up positive, then the provider can discuss with them now, look, I see that you've answered some of these questions in a positive way. Are you interested in mental health services? And it depends. That primary care provider can offer to be the primary source of care for that person, or he can refer them to the primary care mental health integrated team. And so they are actually just what it says. They are integrated within the primary care services, and so they can do the initial assessment. So our team that we have at our clinic right now, it consists of 2 social workers, 2 nurse practitioners. We have a psychologist and a registered nurse that are part of that team right now. Now, a lot of times those services are more limited. So a vet may not necessarily be diagnosed with PTSD in that setting. There probably will be some indicators by that time that, yeah, this really may be PTSD. And we use the PTSD, the PCLM, which is it's a PTSD questionnaire that goes directly according to the DSM criteria, and it's specific to military members. That's the most commonly used tool that we use at the VA. So they might do that. They might use that tool, and if it comes up with a positive screen, depending on whoever's doing the assessment, if they feel like pretty confident that this really is PTSD, then they might go ahead and diagnose them, or they may hold off. But usually, if there's a suspicion of PTSD, that's considered more serious illness and requires a higher level of care. So that vet will probably be referred to the mental health clinic. So they'll put in a consult, and then they'll come up to see us upstairs. And upstairs in the mental health clinic, we have psychiatrists, psychologists, we have social workers, nurse practitioners, we have peer support specialists. There's quite a few. We have registered nurses. We have a pretty good sized team. Within our mental health clinic, we actually are just starting a PTSD program. We haven't had an official PTSD program for a few years, and
so this was a gap in service that you think?
Yeah, it was definitely a gap, and it was mostly related to the fact that we just couldn't get the providers to get the program going. Okay. We have consistently had providers that provide PTSD treatment. So we have 2 social workers that do therapy. One, actually, she just retired, and she used more eclectic types of therapy. So multiple, whatever worked for the individual soldier. And another social worker that uses just a behavior processing therapy. And then we have another soldier that does prolonged exposure. Did I say soldier? I meant social worker, that uses prolonged exposure.
Okay, so these are some treatment tools that y'all use at the VA.
There are different treatment modalities, forms of therapy that specifically to target PTSD.
Okay. The other day, we were specifically talking about there's some hallucinogens that they use. Is that right? Ketamine?
Ketamine. So, yeah, there's some of our VA sites that are starting to use ketamine. It's still experimental at this time, and it takes quite a bit to be able to get into one of those programs right now.
Large medical team.
Well, because it does require a lot of medical care to be able to do a ketamine infusion. It's usually done in a setting where like where you would have anesthesia done. So there has to be a physician, and then there's nurses that will monitor vitals. And then they have to stay after the infusion. They have to stay in the clinic for quite a bit of time afterward, just to make sure that they're well enough to leave at that point. And it's a little, the evidence on that is it's a little conflicting right now. So you get a good, robust, what we're seeing is a very good, robust initial response, but it's just not lasting.
Okay. So they would have to get multiple treatments?
So they may require multiple treatments, and then how long is it safe to do those treatments? We don't.
Side effects, right? So, okay.
Yeah, so that's, yeah. And then there's something called a ganglion block, and I think that they are starting to do those in a few VA sites now, but not
many. Okay.
Yeah,
so it's still kind of experimental at this point.
So here in Pensacola, I've had a couple of vets. Actually, I had one vet that came from Walter Reed, who had because he also had significant physical injuries that were part of the same incident that led up to his PTSD, and specifically neck, back, and shoulder injuries. So he had received the ganglion blocks for that. And it is indicated for the treatment of pain with
receptors.
So there's through the Andrews Institute, which is a huge orthopedic provider here in the area. They are doing some ganglion blocks, but it's just really difficult to get to that and to get vets approved for that.
Get insurance to cover it and everything like that. Okay. So I'm gonna change direction just a little bit.
Oh, can I just tell you about this other lady?
Oh, sure. Go ahead. Tell us.
So she's part of the we're broken up into general mental health providers and then specialty providers. So, but she's considered part of the general mental health, but she really very closely and works specifically with a lot of vets that have had military sexual trauma. And that's kind of her specialty area, is working with military sexual trauma, but also sexual trauma from other sources too. So she's a really good resource for us too.
Okay. Oh, all right. Well, that's actually kind of what I was gonna sort of talk to you about how men and women could express symptoms differently. Do you have some stories or?
Yeah, well, we know that there's some differences in the way that they present, and I can tell you I've experienced it firsthand. Men tend to express PTSD symptoms more with a lot of physical aggression and feeling angry and hypervigilance, whereas women will talk more about emotional numbing and not being able to feel emotions, or they might talk more about feeling extremely anxious. And those are kind of the biggies.
Okay.
Women overall tend to have much higher rates of PTSD compared to men.
Really? I did not know this.
Yes. So I think, the rates of PTSD in the general population is like in the United States, it's about 3.6%. So if you break that down into men and women, I think it's about 1.8% of men end up with diagnosis of PTSD or meeting criteria for PTSD, whereas it's like, I want to say 5.6% of women experience PTSD. And the causes of PTSD tend to be a little bit different.
Okay. Does the cause ever change the symptom at all? The expression?
I can't really talk to that. I don't know. Women, obviously, more problems with sexual trauma. and men more with combat. But I don't know if the cause, I would think so, but I can't, I honestly, I'm sorry, I just can't speak to that.
Okay. One other question, that being said, men are now, coming out a little bit more about their sexual assaults. Have you had any instances with something like that?
I have lots of instances of cases like that. It's still, you know, unfortunately, there's still just such a stigma with any kind of mental health treatment, but it's
Especially sexual assault.
it's compounded with sexual assault with men. And so you have to ask. You have to be clearly asked. And they may not tell you. So that's I think one of the most valuable tools in treatment, more so than any specific therapy, is the relationship. So I think that's really, really important, that you're able to develop that relationship, that trusting relationship with somebody. And you continue to work. I mean, you can suspect trauma, but you have to work within within your vet or your patient,
Right.
within.
And that's where the empathetic relationship was what you said, that comes in. And the more they trust you, the more that they'll tell you.
Yeah, it's really hard, especially with the veteran population. There again, veteran soldiers, there's just a huge stigma. I can tell you it's getting a lot better. I can look and see that it's getting better, but there's still just that stigma that's out there.
Yeah, I can tell you, when I was in, a lot of people were afraid to go to mental health because they were afraid that their careers would be ruined, or, especially, if you're like a cop or something like that and you have to carry a weapon every day, there are going to be times, if you're bad enough, you're going to have to, you know, take away the right to hold that weapon or
Yeah,
carry that.
that's not what anybody ever wants, but you have to maintain the safety of that individual and the safety of the people around them. So yeah.
Exactly.
Like people that have security, a high security clearance, they're those people tend to worry more about it. So.
Right, right. Well, is there anything else you'd like to share?
Um, no, this is just my personal bias. I think that, again, I think the most valuable tool is you and your relationship. Um, I don't know if we went to this conference, trauma conference, but he talked about that a little bit, that sometimes just the combination of the relationship and the psychoeducation is so meaningful and so powerful that that has the potential to alleviate a lot of symptoms. So, I think that's really, really important for people to kind of look and develop skills to work with
To learn
people.
that relationship.
Yeah. And to work with that population, when it's innate with a PTSD, that there's anxiety and there's distrust. So it's difficult for that.
It's hard for them to be vulnerable because of the distrust, and
Yeah.
distrust in the institution that they came from, distrust in the military as well,
Right.
and so when they come into a institution that's made for these people,
And
they can still. Hmm?
the VA is complicated. There's no doubt that it's complicated. It's difficult to get in, to get started, to negotiate the whole system. That's why we have our specific social worker for that. But despite that, it's still very complicated for them to get in. And then when you're dealing with anxiety and frustration and trust issues, wow.
Makes it so much worse.
Yeah, it makes it very difficult sometimes.
All right, well, thank you, Mom. I
Mhm.
appreciate you doing this with me.
Yeah, glad to have to.
All right, well, I'm going to stop recording.